The next transfer we're going to demonstrate is getting somebody from bed to chair using a total or full lift. What we need first is a sling. Sling pad, this is called a horseshoe style sling. You'll notice that the top side is flat. That's going to go under the head and the shoulders. The longer ends are the loops, which will go under the legs. We're going to use a rolling technique to get the sling pad in underneath the patient. Again, we're going to use our safe technique where we hand the draw sheet to one caregiver. That caregiver positions her feet one in front of the other and gently rocks back, rolling the patient towards her. Once we get the patient into about a half turn, we're then going to have her hold her there, and we're going to tuck the sling pad in underneath so it's about halfway. The top of the horseshoe is going to get at the patient's low back, not underneath the buttocks, so that we are able to get it out when we have her in sitting. The loops are going to be tucked in underneath the legs as well, so that they're underneath far enough. We then have the patient roll back onto the sling pad, and if they're able to help, they can help as well with the roll. But now the second caregiver will hand the draw sheet. We will begin to roll the patient to the opposite side. Once we get her turned over where she can hold the position, we take the draw sheet back and then flatten the sling pad out fully. Again, you can see here how the bottom of the sling pad stops at the patient's low back, not underneath the buttocks. We then roll the patient back onto the sling pad. This gets the sling into the proper position. When choosing a lift, you need to be aware of how much the weight capacity is of the lift. They come in several different models. The lift we happen to be using in this demonstration is a 600-pound capacity. They are a 4-point hanger system, and that hanger system, as we'll show you, will connect to the points of the sling. Next, we're going to roll the lift into position. The base of the lift has a wide middle and wide open bottom, and you can position that so that you're able to clear the surface that you're moving around. We can raise the hanger bar up slightly so that it does not hit the patient. We use a minimum of 2 caregivers with a total lift, one to keep track of what's happening with the patient, the other to focus on what's going on with the lift. We then slide the lift in underneath. The hanger bar will go across the patient's midsection, waist to stomach area. We're then going to position the sling loops onto the hanger bar without pulling or tugging. When moving the patient from a lying to a sitting position, it is best to keep the shoulder loops shorter and the leg loops longer so that the patient comes to an upright position. To position the leg pieces, you're going to put the right side under the right leg and the left side under the left leg. And depending on what the activity is, you may keep the right on the right and the left on the left if you're going to a commode or a shower chair. It is more common to crisscross these pieces to provide more stability for the patient. Because we're moving to a sitting position, we want the leg loops to be a little bit longer. For a patient who is an amputee or has discomfort with the crisscross method, you can use what's called a hammocking method, where we bring the sling loops underneath both legs and up, which kind of locks the patient's legs into position and forces them together. So there are several different ways you can attach the sling to the hanger bar depending on what your needs are with the patient. This should be identified in the care plan on the nursing or physical therapy assessment. We will demonstrate the crisscross method for the purpose of this transfer. As you'll notice, anything that comes into near contact with the patient, the hanger bar and the upright of the lift, is padded with memory foam. We have one caregiver taking care of the lift. When we do the lift, we want to unlock the brakes. This allows the lift to swing and find its balance point as we lift the patient up. One caregiver will watch what's happening with the patient as the other caregiver uses the hand controls to lift the resident up. The caregiver watching the patient can support the head if required. As you see as we're coming up, the lift rolls slightly, which helps to prevent a tipping hazard. We only need to go as high as to clear the surface that we're moving to. So as you see, there is a little bit of swinging that occurs as we begin to raise the patient up. That is why we don't lock the brakes. We want to have the two surfaces that we're moving between as close together as possible. So we'll move the wheelchair closer to the surface, move the footrests out of the way, and then lock the brakes to receive that. In an area where there's not a lot of room, you may back the sling up or the lift up first and then move the chair in underneath it. It is best to turn the patient's legs towards the base of the lift as we're moving them. As we lower the patient down, the caregiver that is assisting the patient will lift up gently on the back loops of the sling pad to help to position her upright in the chair. The lift will move slightly as we begin to lower down. The caregiver operating the lift may also assist if needed by pushing down and back on the knees. Once the patient is in a seated position, we can back the lift up slightly, disconnect the sling from the hanger bar, and then move the patient away from the lift, either by moving the lift or the patient or a combination of both. Once the transfer is complete, there may be a situation where we need to remove the sling pad from under the patient. To do this, we uncross the leg loops getting the lower pieces out from underneath the patient or resident. We can then rock the patient forward, keeping a caregiver in front for safety, while the second caregiver gently raises the sling pad out from underneath the patient. This should not require a lot of tugging or pulling. If we need to reposition the sling underneath the patient, we reverse this process. We'll rock the patient forward and use what I call a cape method to position the sling over the patient's back, only getting the top of the horseshoe to the surface that the patient is sitting on. So we'll rock the patient forward. We'll have a caregiver get in front just for safety. We get the sling pad tucked in to the back of the chair, just to the surface that the patient is seated on, pulling the leg loops around the sides, being careful not to capture the wheelchair in the footrests or the armrests so that we don't lift the chair when we get the patient up. The sling is generally slippery enough so that you do not need to pull and tug on it. We then position the leg pieces as we did in bed, using either a crisscross or side-to-side positioning. We would then hook up the lift in the same way to transfer the patient back to bed if required. To connect the lift to the patient in sitting, we're going to pull the lift into place. Again, one caregiver watching to make sure that we don't strike the patient with the hanger bar. We lower the hanger bar so that we do not need to pull and tug on the loops. And we get it into position. When going back to bed, the only thing to be cautious with is to make sure that we are not putting the straps on a shorter position on the legs than the shoulders. They can be equal, or they can be as they would be coming up, where the shoulders are shorter than the legs. But if we ever position the sling pad with the legs shorter than the shoulders, we will lift the legs higher than the shoulders and tip the patient back, which is oftentimes uncomfortable or frightening for them. Once we have the hanger bar and the sling connected, we will again raise the patient up out of the surface. We may instruct the patient to cross their arms across their chest or lap just to keep everything tucked in. And we will raise up slowly, making sure that we clear the chair without raising the chair and making sure the patient's not caught anywhere. We only need to raise the patient high enough to clear the surface. We also instruct the patient to let us know if anything is uncomfortable or bothering them.
That's okay. I'm good.
We would then back her up, move her over to the receiving surface, and lower her down in the reverse order of getting her up. When moving the patient in the lift, we back up away from the surface. What a common way that we see caregivers to try to turn this is that the caregiver tries to twist their trunk using their arm and abdomen muscles, which puts a fair amount of strain on the body. This is not the safest way to do this. When you have room to turn, it is easier to change direction by moving the lift by walking into the direction that you want to go and then moving forward. By walking with the lift to turn it rather than keeping your body stationary, you're able to use the muscles of your legs and use the wheeling of the wheels so that we do not need to work as hard to get the patient to change direction.